This video will describe the labral scaffold procedure. This is a 22-year-old patient with a labral tear from a previous labral repair. She had redislocated. The previous sutures are removed and a pocket is created in the area of bone loss. In this particular case, the patient had a 5 millimeter area of bone loss. Once the pocket is created, an anchor is placed. We use a curved guide in order to place a knotless anchor just below the articular surface. A flexible drill is used through the curved guide, followed by the anchor being tapped in place. Once the anchor has been tapped appropriately in place, the sutures are cycled in order to make sure that the graft will be able to slide easily over the repair stitch once the graft is ready. In terms of graft prep, 1 centimeter by 1 centimeter dermal allograft that are 3 millimeters thick are stacked. A suture passing device is used to pass a suture link through the graft. You want to make sure that the loop of the suture links are going in different direction in order to create a mattress once the graft is brought into the field. The graft is measured to ensure that it fills the defect, in this case 5 millimeters. The repair stitch is brought into the suture link to pass the first limb of the repair stitch. The repair stitch is then passed through the second limb, creating a mattress through the graft. This is done on the field. A finger is placed in the loop of the mattress in order to place a traction stitch, which is one of the links that was in the graft. The graft is then brought to the field where the repair stitch is loaded into the anchor. Once the repair stitch has been loaded and passed through, a grasping device will be used in order to introduce the graft past the dam of the cannula. At this point, both the repair stitch and the traction stitch are used in order to take slack out of the repair as the graft is slid into its appropriate position into the shoulder. Once the graft has been placed in the appropriate position, it should be sitting right in between the labrum as well as the glenoid. The link suture that was used as a traction stitch is then converted in order to provide an additional stitch that will be passed through the capsule. This demonstrates the appropriate placement of the graft between the glenoid and the capsule. A suture passing device is then used to pass the suture through the capsule, using at first the link suture that is behind the graft, and a second pass is made through, this time through the labrum, using this to pass the repair stitch from the actual anchor itself. Once the repair stitch is brought close, it is loaded so that it sits in front of the graft, providing additional barrier for the graft to be inside the shoulder. The final product should have 2 passes, both the suture link as well as the repair stitch through the capsule. Both of these sutures are then brought with a drill over the top in order to fix the graft. Once the eyelet of the anchor is introduced, the sutures are tensioned differentially in order to tension not only the capsule but also the graft as well. Once appropriate tension is achieved, the graft is then placed. At this point, 2 options remain. If additional bony defects remain, the process can be repeated. Otherwise, additional anchors can be placed. In this case, an additional anchor was placed below the dermal allograft in order to provide a capsule shift at the 6 o'clock position. An additional anchor was then placed at the 3 o'clock position in order to close down the capsule superiorly. The final product shows you that the graft is sitting in an extra-articular position, buttressing the labrum and filling the area of bony defect with a dermal allograft.